Wonderful. Thanks so much. Such a pleasure to be here. First, just to make sure everyone can see my slides and slideshow view and can hear me just fine. Excellent.
Loud and clear.
Perfect. All right. So very happy to give two talks, two areas that are very near and dear to my heart. The first one we'll talk about disease-modifying therapy or anti-angiogenic pathway-directed therapy in HHT. And then I think there's a short Q&A and break, and then I'll talk about anemia and iron deficiency in HHT. So here are my disclosures. These are universal disclosures. So I like to start, and I know that my audience here is mostly patients. And so I like to start my talks about HHT and about bleeding disorders, just reminding us what the spectrum of bleeding disorders are, because we hear about bleeding disorders, you hear about, from the patient perspective, you may be familiar with the National Hemophilia Foundation and other groups outside of Cure HHT that also are patient advocacy groups for bleeding disorders. And so you may ask, what is the relationship here? All right. And it's relevant because of the way we treat HHT versus other bleeding disorders, and which is really the topic of this talk, these therapies in HHT. So bleeding disorders kind of fall on a spectrum, and there are three major bleeding disorders. The most common is von Willebrand disease, affects about 1 in 1,000 people. Von Willebrand disease is right in the middle. It is caused by a coagulation factor deficiency, but that coagulation protein deficiency causes the body to have abnormal blood vessel growth and generation. 90% of patients with von Willebrand disease have objective evidence of this, and they can develop telangiectasias and arteriovenous malformations. Not quite the same as an HHT, but still can happen, and not infrequently does happen in these patients. Hemophilia is the bleeding disorder that's the third most common hereditary bleeding disorder after HHT, which is the second most common. Hemophilia is purely a coagulation factor problem. A blood protein called factor VIII is deficient, and patients with hemophilia need to have repletion of that in order to treat their disease. That is, hemophilia is a major disease and has major, causes major suffering, can be fatal. But when we think about, what's wrong and how to fix it, the treatments that are directed at hemophilia came about many decades ago because there's one protein that's missing and we can replace that protein and things are fine. Now, there are issues related to that. The protein doesn't last very long. You have to give multiple infusions a week. The immune system can make antibodies against it, all of these other problems. But from a therapeutic perspective, this was kind of wrangled, I should say, many decades ago. HHT is a little different. So HHT is on the other end of the spectrum. There's no coagulation protein problem. The coagulation proteins are fine, but patients with HHT can bleed and bleed and bleed. And that's because there's abnormal blood vessel growth and development called angiogenesis. So we say disordered angiogenesis. And that's a harder nut to crack. We only discovered the sort of main what we call angiogenic hormone or protein, which is called vascular endothelial growth factor, in the late 80s. Whereas in hemophilia, they had discovered that factor VIII was missing many decades before that. So we're kind of a little bit behind the 8 ball in the grand scheme of things in developing therapies in HHT, but that's changing now. And that's what the topic of this talk is about. So I know that this audience is very acutely aware, very likely many patients in this audience have had procedural management to manage HHT. And I say before drug therapy, and drug therapy has been around in some way, shape, or form for a long time in HHT, whether it's hormonal therapy or antifibrinolytics, and I'll talk about that. But generally speaking, for decades and decades, the main means to manage HHT-associated bleeding, and that's what I'm focusing on. I'm a hematologist. I'll talk about the bleeding. The main ways we used to address the bleeding has been with local procedures in the nose and in the gastrointestinal tract. These procedures obviously can work. They can. The benefits are generally felt to be temporary. For most of these standard procedures, laser, electrical, chemical cautery, things like sclerotherapy or embolization. Then there are surgeries, septodermoplasty, which is like a skin graft to the inside of your nose, and a nasal closure or Young's procedure, which as obviously a drastic step, and I don't know if anybody in the audience has had that done. But this is how things used to be managed. And with gastrointestinal bleeding is really difficult because what we're able to do with gastrointestinal telangiectasias is sort of limited from a procedural standpoint. We can kind of burn them, we can clip them. There's concerns that when we do this, that we may be provoking a local healing response, both in the nose and the gastrointestinal tract, that actually increases the hormones that are dysregulated in HHT that cause this abnormal blood vessel growth, and that we could actually be stimulating more blood vessels to grow where we intervene. So it is important to recognize that now we have a balance between systemic therapy or drug therapy and procedures. So to talk a little bit about some of the systemic therapies in HHT before we dive into the main focus of the talk, which is, as was stated, Bevacizumab and some of these newer drugs. Antifibrinolytic drugs are medications. They're pills. They can also be used topically, but they're usually used as pills, or they can be given intravenously in the hospital, that help promote, they help prevent the breakdown of blood clots. Sort of imagine when there is bleeding, your body works to create a blood clot, but that process is a very dynamic process. There's clot being formed and clot being broken down all at the same time. And these drugs kind of tip those scales where they try to make it so that the clot forms much more readily than it will disintegrate. And that's why they're called antifibrinolytic. The fibrinolytic process being the pathway of the process physiologically by which a clot is broken down. And so there were two very important clinical trials in HHT patients of an antifibrinolytic drug called tranexamic acid, TXA. There's another drug called aminocaproic acid, or Amicar, which is also a perfectly reasonable medication to use. And in these trials, we saw some pretty good and some significant improvements in bleeding in patients who had HHT, primarily nosebleeds. There's a couple important things to note. Patients did not have an improvement in their blood hemoglobin, a measure of blood cell mass in the body, and that did render some of the primary endpoints, as we say, negative in these studies. But nonetheless, there were some clearly positive secondary endpoints, things looking at nosebleed duration and composite nosebleed endpoints in these studies. And they, using them clinically, they certainly can help. I think of these agents as best in patients who have more mild to moderate HHT-related bleeding, and they can really help take the edge off of that bleeding. It can help reduce nose bleeding, and can also help with gastrointestinal bleeding that's mild. So hormonal agents in HHT, there's a very old study from the early 80s that was a randomized study, meaning they put patients on active medicine or a placebo. That when a randomized study is double blind, they don't tell the patient what they are getting. They don't tell the doctor what the patient is receiving. It's really the sort of gold standard for a clinical trial. There was an old study that showed no improvement in patients receiving oral estrogen. Estrogen, you might say, why estrogen? Estrogen actually increases blood clotting factor production by the liver. And so it's sort of a physiologic thing. One of the main things that threatens a woman who is pregnant is bleeding. And so hormones in pregnancy actually raise the estrogen and other estrogenic hormones, progesterone and so on and so forth, raise the levels of these blood clotting factors in the pregnant state to try to prevent, potential loss of the fetus, life-threatening bleeding, all of that. And so when you give somebody estrogen, it actually increases their blood clotting factors, which can be very helpful in reducing bleeding. In HHT, there are some studies that show a benefit of these drugs that are called selective estrogen response modifiers, or SERMs. And these drugs they were originally developed to treat osteoporosis, and they're used routinely to treat breast cancer, and they have a known blood clotting risk. Right. And we care about that blood clotting risk, certainly in patients who have osteoporosis and breast cancer are receiving these drugs. We really, really care about it in HHT. And so, the set of drugs I talked about, which are called antifibrinolytics, again, those drugs have what we would call a theoretical blood clotting risk. there's some decent data to suggest, and multiple clinical trials in other disease states to suggest that those drugs don't really increase your chance of clotting substantially, at least not in a population level. With the case of hormonal drugs, including SERMs, we know they increase the risk of blood clotting. And so we really try to avoid using these in most patients. There's certain patients where this might be the right choice. And certainly, right, if somebody is, for example, being treated for their breast cancer, or they're being treated for osteoporosis, and they have HHT and bleeding, this could be something that could be used to have, hit multiple birds with one stone. Now I'm going to talk a little bit about antiangiogenics for bleeding in HHT. All right, so what is an antiangiogenic? Angiogenesis, as we said, is the process by which blood vessels grow and develop and mature. Systemic means that this is a medication that's given throughout the entire body, given by mouth or by an intravenous infusion. Okay, so not something that is topical on the skin or injections into the mucosa of the nose only. These are medications that go everywhere. Antiangiogenics then are medicines that block angiogenesis, so that reduce the body's pro-blood clotting factors. Now, in HHT, we know that many of these proteins are abnormally elevated. And so when we use antiangiogenic therapies, our goal here is to try to reduce the elevation of that signal in the body and normalize the signal so that these abnormal telangiectasias that form in the nasal cavity, in the gastrointestinal tract, on the skin, in the mouth, as well as the arteriovenous malformations that form in visceral organs, lung, liver, brain, and so on, we want to reduce the signal of the body to create those things. That is the clinical manifestations of HHT. So bevacizumab, or Avastin, is one of its brand names, has many brand names now because it's available as there are biosimilars of this drug available now too. Bevacizumab is really the first anti-angiogenic agent evaluated to I think a significant degree in HHT. This drug is developed for cancer. Most of these drugs I'm going to talk about were originally developed to treat cancer. Cancerous tumors, they trick the body into growing them a nice, robust blood supply. They release these hormones that promote angiogenesis, blood vessel growth, and in gaining that blood supply, the tumors can grow and spread. And so these drugs were originally developed to treat cancer. If you reduce that signal, then you can starve the tumor of the blood that it needs and the nutrients it needs to grow. These drugs, have been reasonably effective in cancer, not a slam dunk by any stretch, perhaps not quite as promising as they originally were hoped. But there were some early serendipitous case reports of patients who had cancer, who also had HHT, and who were receiving this drug bevacizumab as part of their chemotherapy regimen. And they noticed they had really substantial improvements in bleeding. And so that, really rose people's eyebrows and made the light bulb go off that, wait a minute, this might be a really good drug to repurpose and use for HHT. And we'll talk about that. There's another drug that I'm also going to touch on. I'm going to touch on a few more. A medication that some of you may be familiar with called Thalidomide, which is an oral drug, very old drug, developed a very long time ago, that was originally developed for insomnia in pregnant patients, and unfortunately caused birth defects in fetuses, and that's kind of where it kind of had a claim to infamy, so to speak. But thalidomide and other drugs that are related to it are now being used in HHT, and I'll talk about that too. So this figure here shows the standard of care for bleeding in HHT right now. And this is really a summary of these of what's recommended in the Second International HHT guidelines. The initial management is moisturizing topical therapies, which every patient with HHT, really every human being, should be doing, especially in the winter months and when there's dry air. Topical therapies, everything from nasal saline, humidification, emollients spread in the nostrils. there's a whole host of these things, and they're the first line, but they're often not enough, right? So we then, for nosebleeding, we'll go to, we have here oral tranexamic acid. And like I said, there's another drug called aminocaproic acid that also works. This is that antifibrinolytic I mentioned before. And then local ablative therapies, which again, I mentioned before. Now, once the patient has, worsened bleeding that's not adequately helped by these, and we really try to avoid doing dozens and dozens of local ablative therapies, you can cause nasal septum perforation and other complications. We then go to the next stage, which, as you can see there, includes systemic anti-angiogenic agents, and then these 2 nasal surgeries I mentioned before, septodermoplasty and nasal closure. In our practice at our center, we really are opting for drug therapy before we consider these other more significant surgeries, but all of them are potential treatments. For gastrointestinal bleeding, we see that at the time that the proceduralist is doing the scope and looking in the gastrointestinal tract and the stomach or the intestine, if they see bleeding lesions, they can address them. But we really are encouraging them not to go and try to cauterize every single telangiectasia they see, again, because we don't want to provoke that wound healing response that may leave you with more telangiectasias a year later than you had at the time of the scope. Then we talk about antifibrinolytics, same as with nose bleeding. And then we talk about antiangiogenic agents. So with gastrointestinal bleeding, it's a little bit more simple in terms of the choices, but we see that in both nose bleeding and gastrointestinal bleeding, and many patients suffer from both, antiangiogenic agents, because they go everywhere. These systemic drugs, they go everywhere. They go to the gastrointestinal tract, they go to the nose, they're carried in the blood. They can treat all these different kinds of bleeding. So bevacizumab is an antibody. It is what we call monoclonal antibody. It's an engineered antibody to bind one of these very important hormones called vascular endothelial growth factor, or VEGF. Your body normally makes antibodies to fight off bacteria and viruses. This is an engineered antibody, which is a very common mechanism now where we develop drugs and treating various diseases. We bioengineer our own antibodies to target something, because antibodies will exquisitely target it and will be able to clear it from the body. And so bevacizumab does just exactly that for one of these very important hormones called VEGF. And we dose it at a dose of 5 milligrams per kilogram in HHT, which is about half of what we normally use in patients with cancer. We also often will give it less frequently in patients with HHT for the long run than we do in patients with cancer. So it's not quite the same amount. You may be wondering, like, am I getting the same amount a cancer patient is getting if you get this drug? Not generally, but you may get it for longer. Cancer patients often get it for just a few months, then their tumor progresses and they go to a different therapy. For people HHT patients for whom bevacizumab works, they will often receive it for a long period of time. We usually will start a patient with a series of 4 to 6 induction infusions, which are given every 2 weeks. This is just given by itself, no other medications given with it. And then we can, if a person has a good response to that, which we find out pretty quickly, within 2 to 3 months, we will really know how a patient will respond. If they've had a great response, then we'll continue. In many cases, by giving what we call maintenance infusions, or continuous maintenance, where we can give an infusion every month, every 2 months. We can start with every month and then space it out. I have patients that are getting infusions every 12 weeks, so quarterly, 4 times a year. That's one choice. Another choice is what we call intermittent maintenance, where we say, okay, we've given you 6 infusions, we're going to watch you and see what happens. And maybe you won't have rebleeding for a long time. And then when that happens, we can then give you more infusions. And so that is another option. And both of these options are very reasonable. And it just depends on the right choice for the patient and what's available. Now, bevacizumab, or really antiangiogenic therapy in general, can be life-changing for patients with HHT who have really severe bleeding. I say that it's appropriate. I mentioned that antifibrinolytics we think of for mild to moderate bleeding. I like to think of antiangiogenics as appropriate for moderate to severe bleeding. Not everybody. Not everybody should be, banging down the door to get these drugs, because drugs have potential side effects, right? But this is an example of a patient who was a fixture in our blood bank, who came in every couple weeks to get her transfusions. And the red arrows there are units of blood that she got transfused. And we see on the x-axis, we can see the time in weeks. And we see her hemoglobin as the blue line. Normal hemoglobin for a woman is above 12. And we see here that she was dependent, completely red cell dependent, dependent on blood transfusions, and then started bevacizumab. Those are the green arrows. And we see her hemoglobin improve remarkably in a relatively short period of time, and her need for blood completely go away. All right. And this woman did very well on bevacizumab for many years. And then after about 5 years, the medication didn't seem to work as well. And instead of getting the drug monthly, she needed it every 2 weeks. And even though getting it every 2 weeks, she wasn't able to quite maintain her hemoglobin. So this happens in some patients. Some patients we treated for 8, 9, 10 years, and they're doing great. Other patients, after 3 years, 4 years, the drug doesn't work as well. This is something that we don't understand in HHT, but for this patient for many years, this drug was a godsend. This is an example of an early case series of bevacizumab use in HHT, okay? This is a swimmer plot, okay? What is that? If you look at each of these horizontal lines on the plot, each lane in the swimming pool, each of those represents the course of one patient over time. And we see that on the x-axis here at the bottom of the graph, we have the time in weeks. First negative numbers, that's the time from bevacizumab initiation, and that black triangle is when bevacizumab is started. We have the induction period, as I mentioned, a series of infusions every 2 weeks, and then maintenance. And patients here receive 1 infusion every month during maintenance. Every single red dot is a time where they receive blood. The bigger the dots, the more units of blood they received at that time point. Every single blue diamond is a time where the patient received iron, IV iron. And the larger the blue diamond, the more IV iron the patient received. You can see before starting bevacizumab that most of these patients had quite a lot of needs for blood and iron. This is just basically a 6-month period represented before bevacizumab initiation. And then we can see when bevacizumab is started, and then we see what happens during the maintenance period, where most of the patients don't need anything. They don't need any blood. They don't need any iron. Didn't work for everybody, though. You can see that there are a couple patients that still needed support. This is what happened to their hemoglobin. Normal hemoglobin for a man is above 13.5, 14. Normal hemoglobin for a woman is above 12, 12.5. And we can see here that before patients started, their average hemoglobin was about 8. And in the maintenance period, their average hemoglobin was above 12. Most patients had normalized their hemoglobin. And then many patients had a peak on treatment that was very, very robust. One thing that people ask me about, will this make my spots on my face and my tongue and my lips go away? Maybe, often. It's very, it can be very, very satisfying, I should say, for patients and for doctors to see this happen. And it absolutely can happen. Doesn't happen for everybody. Sometimes the telangiectasias are more established, but oftentimes they do fade away. I'm going to talk a little bit about what we call the Inhibit Bleed study. This was a very large study of patients, 12 centers around the world receiving bevacizumab. This is what we call an observational study, meaning that patients were treated by their docs with bevacizumab off-label at their institutions. And we looked back and we said, okay, let's take a look at how these patients did. So these patients weren't enrolled on a clinical trial. They were just treated. And then we looked back and saw how they did. This study looked at everything that we really are focused on when we're talking about bleeding. Hemoglobin, again, that measure of red cells in the body. The epistaxis severity score, which is a very well-established, validated bleeding score in HHT. Red cell transfusion requirement, iron infusion requirements, and then safety, adverse events that we saw. So this study had 238 patients that received bevacizumab for a median of 1 year, but some patients received it for as long as 8 years. The majority of patients, 181 of them, received some form of maintenance treatment, as I had mentioned before. This patient population really included lots of, it didn't include children, which is all adults here, but people in their 20s up to people in their 90s, 62% female, and the vast majority had what we would consider definite HHT by the Curacao diagnostic criteria, all different mutations represented. And many patients had underlying medical problems that we are concerned, we have some concern for when we treat patients with this medication because of its potential side effects. We can see that very much like that small series I showed you, really substantial improvements in hemoglobin from a baseline of 8.6, which we would consider, firmly a moderate anemia, all the way up to almost 12, a mean of almost 12 grams per deciliter on treatment. That's normal for a woman and close to normal for a man. Really impressive improvement. Same thing with the epistaxis severity score with an improvement of about 50%. And this, 0 to 10, 10 is the worst, 0 is no nosebleeds. The average was around 7 and dropped to around 3.5. We look at the effect of bevacizumab on red blood cell transfusions. We can see that in those patients who needed transfusions before starting the drug, they needed a median of 9 units before in the 6 months before they were treated, and then in the 6 months after starting, they needed a median of 0 units, and that benefit was continued. And it's very similar with iron infusions. For those patients that needed iron infusions before starting, we saw that their needs really plummeted from a median of 8 in the 6 months before treatment to 2 in the first 6 months of treatment and 0 in the second 6 months of treatment. We always, safety first. Safety is the most important thing, right? So we want to make sure that we're not causing untoward side effects. And this was very reassuring in this regard. The most common side effect was high blood pressure or worsening of pre-existing high blood pressure. This is usually pretty easy to treat, but it happens about 1 in 5 people who get this drug. Fatigue was noted. Again, how much that fatigue was from the drug versus from anemia is unclear. Proteinuria or leakage of protein in the urine is probably the second most common side effect with this drug. That's something that we monitor for, and it's important that patients receiving bevacizumab have monitoring of their urine tests regularly to make sure that they're not losing protein in the urine. And if they are, you have to reduce the dose of bevacizumab or you have to do something to address that. Space out the infusions, try to make it go away. There were no patients who died of complications related to bevacizumab treatment in this study. There was no increase in side effects in patients who received the drug for longer periods. The study analyzed more than 2 years versus less than 2 years. That's long, longish. It's not really long when we think about the long term, but for a study like this, 2 years of treatment is a pretty long time. About 5% of patients in this study discontinued their treatment because of side effects. 5% for inadequate treatment effect, and 2% because they couldn't afford, there were financial issues related to their receipt of the drug. So that's bevacizumab. All right, I'm going to move on and talk about, we're going to have question and answer, and I know many of you may have questions about bevacizumab, but we're going to move on and I'm going to talk about a few of the other options, including the pills that we use. So thalidomide is a pill, like I said, been around for decades. More than half a century at this point. It fell out of favor a long time ago when it was recognized that it unfortunately caused birth defects and kind of was revived about 20 years ago when we realized that it was quite effective for a blood cancer called multiple myeloma. And use of this drug in multiple myeloma, really created more comfort around its use in general and a system that prevents patients who have a monitoring system that prevents patients who are pregnant from ever taking or receiving the drug. And so it's a very controlled drug, but it's available. And there have been some studies in HHT because we know that this drug and others in its class that are like it do downregulate this hormone called VEGF and improve the frail blood vessel walls in patients with HHT. So recognizing this, there were some studies, including what we call a phase 2 study that looked at the safety and effectiveness of this drug in HHT. That study showed clear improvements in hemoglobin, nosebleed severity, red cell transfusion requirements, and health-related quality of life. All these things we care about. The problem with thalidomide is that in many patients who take it for a long period of time, which is necessary in order to maintain its effect in HHT, it can cause neuropathy. nerve damage in the hands and feet, that neuropathy can be permanent. And we recognize this from use of this drug in patients who have this blood cancer myeloma. So we really do, approach it with caution. Thankfully, there are other drugs that should work similarly to treat bleeding that don't have the neuropathy risk. One of them is called pomalidomide, all right? And there is a study called PATH-HHT that is ongoing right now. Actually, I'm going to go back to this slide in a second. Here's my PATH-HHT slide. This just shows this study is ongoing right now at multiple sites in the United States. And it is a randomized study enrolling 159 patients, treating patients who have moderate to severe nosebleeds and HHT with either pomalidomide or a matched placebo. This study will hopefully, we are very hopeful it's a success, and it will let us know if this drug is safe and effective in HHT, in which case it may become a more established treatment option. So, sorry, here we go. Where was I? I was right here. So I just wanted to highlight, now that we're through bevacizumab and thalidomide, and we talked about some of the other options, sort of where we are at this moment. And this comes from the Second International Guidelines for HHT. They're called Recommendations of Highest Relevance to Hematologists. I'm a hematologist, but this is really the highest relevance to bleeding and clotting. So this really highlights that we talk about antifibrinolytics for bleeding, kind of more mild bleeding. We talk about antiangiogenics for more moderate to severe bleeding. And, we really recognize that there is a lot we know about these drugs and a lot we don't know about these drugs, and that ongoing study is critical. I mean, I have a study that's being funded by the National Institutes of Health in the United States, a clinical trial investigating bevacizumab. Okay, right. So the story is not over on that drug, not by a long shot. We need to know more about what it does, but we know for many patients, it works, and many patients can't wait years and years and years for all of the data and for the full story on all of these things to come. And for those patients, it is quite appropriate to pursue clinical trials of these agents and to receive these agents in the off-label setting if felt to be in their best interest by their HHT provider and themselves as sort of a shared decision-making. I want to talk about a couple other drugs. So Posopanib is another medication, a vascular endothelial growth factor receptor blocking tyrosine kinase inhibitor. Okay, so this blocks the receptor for this hormone rather than the hormone itself. So it's a similar concept to bevacizumab, but different modality of how the drug works. And this is a pill. And in a proof of concept study led by Dr. Fawnin, actually, this drug showed very, very promising early activity in patients who had bleeding in HHT. And 6 out of 7 patients in this early study had more than 50% improvement in their epistaxis severity score. 4 out of 7 had 2 or more gram improvement in their hemoglobin. And really, the drug was pretty safe overall. And so I'll talk more about that in a moment. I already mentioned pomalidomide, which is this thalidomide derivative, which, as you can see from the structure there, the molecular structure looks very similar to thalidomide, which does not have the neuropathy concerns that thalidomide does. And there was a phase 1 study of this drug in HHT that was also promising, which led to that phase 2 PATH-HHT study I was mentioning, this right here mentioned before. So we have some more data on Posopanib, and I always think a picture is worth 1,000 words. And these are 13 patients that have HHT, blood transfusion dependent. The vast majority of them really had no other treatment options available to them at all. Many of them were referred to hospice because their bleeding was so severe. And you can see from this swimmer plot, right, which is similar to the one I showed you before, except with even more dots on it, all right, before patients started Posopanib. Then we see in the middle there, that black vertical line, patients start Posopanib, and then afterwards we see a much clearer, we can actually see the lanes because there aren't so many red dots, blood transfusions, and blue diamonds, which are iron infusions. And so, with the data from Dr. Fawnin's study, as well as this study, we're very excited about an ongoing, or about to start, phase 2 study of Posopanib, phase 2 and 3 study of Posopanib to treat bleeding in HHT. That's going to be opening at multiple sites here very soon. And that hopefully will also be an option. There's another drug called VATO44, which is an inhibitor of a protein called AKT. And this is really starting to get to be alphabet soup. I don't want it to be overly complex, but just to say very briefly about this drug, this is a new mechanism of action that none of these other drugs really exploit. Ultimately downregulates angiogenesis like the other drugs do. It's currently in a phase 1 study. This is the first drug of its type really to be developed by a pharmaceutical company explicitly for the treatment of bleeding in HHT. All these other drugs that we're talking about here are repurposed from other things, cancer or other things. So I wouldn't be a complete talk without mentioning doxycycline. All right, doxycycline is an antibiotic that many of you may have received for acne or for a tick bite or for just various skin and soft tissue infections. Doxycycline is a drug that's been around for decades, and it may have antiangiogenic properties. There was a study called the Nostril study done by my colleague, Dr. McWilliams at UCLA, that randomized 22 patients with HHT to receive doxycycline. And there was some, observational data to suggest that this drug worked in HHT, and we're all really hopeful that this study would be positive. And unfortunately, it was not. All of the endpoints that they looked at, the primary and secondary endpoints, things like hemoglobin, duration of nose bleeding, blood transfusions, all of these things, there was no difference between the patients, the same 22 patients when they received drug from when they received placebo. The way this trial worked was the patients received drug for a period of time, then switched over to placebo, and some patients received placebo first and switched over to drug. Similarly, a study led by Dr. Fon and her group looked at doxycycline as well. And unfortunately, this was a bit of a casualty of the pandemic in which the study had to be halted early after just 13 patients enrolled. The study was not a positive study. In other words, did not show a effect for doxycycline in reducing bleeding significantly in this study, unfortunately. But again, wasn't able to recruit to its full potential. I think the conclusion that I have about doxycycline that is that this is a low risk drug. It's not a zero risk drug, but it's a low risk drug. Some patients do feel that it does help. I personally have tried many patients on it. I haven't had anybody who's really stayed on it and really had durable long-term improvements. I had some people who have noticed some improvement, then it goes away. But that's not to say that it doesn't work for anybody. It's just to say that the way we do our trials and these relatively small trials haven't been able to detect an improvement at a population level. So with that, I don't know if I'm over time or where I am with time, but I'm happy to take questions, however many questions, and then we can go to the next talk.
Thank you so much for the great talk on all these different new therapies that are being studied. There's a couple questions that have been asked, and I'll ask them here right now. Firstly, we have, can systemic antiangiogenic therapies reduce my ability to heal, for example, with wounds, or reduce my chance of contracting cancer since they are traditionally used as chemotherapeutics?
That's really an excellent question. So the answer to the first question, can it reduce your ability to heal? The answer is yes. And so we, in particular, Bevacizumab, we really avoid its use whenever we can around surgery, right? So if somebody is receiving regular Bevacizumab and they have a minor procedure, I advise that they have the procedure at least 2 weeks away from a Bevacizumab infusion. If they're having a major procedure, I advise at least 4 to 6 weeks away. So this can sometimes result in us holding the medicine for a while. Now, obviously, not everything is planned, right? People on Bevacizumab get into car accidents and need emergency surgery, and other urgent things come up, And when that happens, we do the best we can, and the patient, there is a chance that they'll have slower wound healing. That's something that's recognized. Even in those settings, it's very rare to have a non-healing surgical wound or develop a non-healing ulcer or something like that. It can happen, and it's something that is before starting the medication, and it's something that the doctors taking care of the patient, they need to know they're on the bevacizumab so that they have that recognition and that there can be planning of surgeries accordingly. The second question, can it reduce your risk of cancer? That's a great question, isn't it? And I'll expand that question and say, if someone who is 40 years old and has bad bleeding from their HHT, if they're started on bevacizumab and they're on bevacizumab for 10 years or 20 years, will they not develop liver AVMs or pulmonary AVMs throughout their 40s and 50s that they would have developed if they weren't on bevacizumab? I don't know the answer to that question. I have no idea. Is it possible that there may be some kind of long-term downside to being on bevacizumab for 10 or 20 years? Sure. We haven't seen it, but it's absolutely possible. So we have to go into this recognizing we know a lot, but we also don't know a lot. I would not use bevacizumab as a cancer prevention drug, or I wouldn't go toward these therapies for that purpose. Is it possible that they may reduce the risk? It is possible. I've had a patient, one of my patients has SMAD4 positive HHT and has just absolutely horrible gastrointestinal polyps, which are precancerous lesions, which become cancer. And he needed every 6 months, or even more frequently, a gastroenterologist to go in and cut out every single one of his polyps. Until we got him started on bevacizumab to treat bleeding. It actually didn't work that well for his bleeding, unfortunately. But his gastroenterologist called us up and he was like, this is incredible. What have you done? Because there were no polyps. He didn't need to cut out the polyps. There's very, very few polyps. So this is not something we expected or anticipated, but it's something we saw. And this is an N of 1, right? I'm not saying this is going to be true for everybody, but could there be really unforeseen beneficial effects in terms of cancer prevention? Possible, but that's not a reason to use the drug.
Awesome. Thank you so much. We have another question here as well. Is there an age restriction to using bevacizumab to treat HHT, as in has it been approved for use in children? And are there any pharmacological therapies available for children with HHT? Yeah,
so there are no approved therapies. There are no FDA-approved therapies or EMA-approved therapies. The regulatory agency-approved therapies for this drug for this disease don't exist yet. But we're working on that. Bevacizumab is approved in adults with multiple different kinds of cancer, and we repurpose it. It's also approved for actually. Similar drugs are approved for use for certain retinal diseases, certain eye diseases characterized by too much blood vessel growth. It is used in children who have cancer, okay? But we have to recognize that a child who has a brain tumor or a child who has metastatic colon cancer, that's a different risk-benefit calculus than a person with HHT, who is expected to live for decades and decades, and somebody who has incurable cancer, right? That's a different story. So I do not use bevacizumab in children. It is possible for use of a drug like that in a child to cause changes in growth and development that would not be welcome. So it's we need more data in children, I think, before we could consider using it in children. In terms of some of these other pathway-based therapies or antiangiogenic therapies in children, I think we really for many of the same reasons we don't use these drugs in children with HHT. What we do use is antifibrinolytics. Antifibrinolytics can be helpful in children who have HHT. Tranexamic acid, aminocaproic acid. These drugs can be helpful and safe. We use them in children who have HHT, hemophilia, von Willebrand disease, any kind of bleeding disorder, and they're often very well tolerated and very safe. But we usually wait. And thankfully, most children don't have severe enough bleeding before age 18, before they reach maturity, to need antiangiogenic therapy. That's not to say that nobody does, but most don't. So right now, we have to always respect safety, and for that reason, we don't go to those drugs in children.
Great, thanks so much. Another question that we have here. It seems that all the current array of drugs targeting targeting angiogenesis. Are there drugs with alternate strategies in the pipeline, or is targeting angiogenesis the way to go now?
For what has been announced, I mean, so there are other drugs that are being repurposed. And again, I recognize this is supposed to be a 25-minute talk, and I don't want to inundate everybody with all these names and alphabet soup and everything. There are other drugs that are being evaluated that work differently. A drug called octreotide, for example, is used to treat patients who have gastrointestinal bleeding outside of the HHT world, and we're starting to use it a little bit in the HHT world. There's a drug called tacrolimus. There are all sorts of drugs that aren't necessarily anti-angiogenic agents. Octreotide is not, for example, but it can be used to treat gastrointestinal bleeding. I think when we talk about drug development in HHT right now, it's really focused on this angiogenesis piece, because we know that that's one of the main underlying problems, and so and we've seen rather impressive success with some of these drugs I've initially showed you. So, are there potentially other drugs that could be very, very helpful that don't fall in this class? Yes. Are there drugs that are being developed, again, not like developed by a pharmaceutical company, but being investigated by scientists and clinicians everywhere around the world that don't fall in this category? Yes, there are. What will pan out from that, I don't know, but I know that where most of the funding in terms of the U.S. government funding, for example, and where the pharmaceutical industry, for what little they're looking at it, are looking right with Vidaris and Beto-44, has been this angiogenic space.
All right, so it's interesting that you brought up tacrolimus. Someone was asking here if you're aware of any tacrolimus studies in HHT.
Yeah, so there are case reports and there are some case series, and this drug may be helpful. It may be helpful in reducing bleeding in HHT. What we really need, ultimately, right, are larger randomized studies. So I showed you the PATH HHT study. This is a good example of this is not even a phase 3 study. So drugs and development go through 3 main phases after animal studies. Phase 1, often in healthy volunteers or sometimes patients with the disease, really to evaluate safety. Phase 2, to evaluate safety and efficacy. And phase 3, to compare the drug to a placebo, although sometimes that's done in phase 2, as is the case here. And we have to go through all these phases. Phase 3 really confirms the safety and effectiveness of the drug. This is a good example of the kind of study that can really tell us whether or not a drug works, because it's 159 patients. So it's a really, I hope it's going to be a definitive study, but it's designed that way to be a more definitive answer. I can't say for something like tacrolimus, because there just isn't a huge body of, there isn't even a large number of patients like the Inhibited bleed study for Bevacizumab, 238 patients receiving it retrospectively. I don't have that for tacrolimus. Is it possible it could help? Yes. Have I seen patients in whom it has helped? Yes. But that drug is not without its own potential side effects as well.
Okay, great. So another question we have here, just clarifying how Bevacizumab and other anti-angiogenic treatments work. Do they only help prevent the formation of AVMs, or are they able to also correct AVMs that have already formed?
Yeah, that's a great question. They clearly can do both. I think I showed you, the picture here of the patient before and after. These are telangiectasias in the before picture, and they're faded away in the after picture. What would happen to this patient if they stop bevacizumab? Well, these things just come right back, maybe, and we do see that. We often get asked about AVMs in the brain, in the lungs, in the liver. Can this drug treat those? Well, we have a study that looked at bevacizumab in the liver for liver AVMs that did suggest that it's helpful. And there's been other data that's been published to suggest that this drug can help with liver AVMs and the manifestation of liver disease and HHT. I've never personally seen it help when somebody who has big AVMs in the liver. I don't think it's going to shrink them down. I think it's something that an intervention that could help earlier on in that course, or for those patients that have many, many tiny AVMs, but not for some 7-centimeter AVM. I've never seen it work to reduce the size of something like that. We don't know about lungs. We don't know about brain. We just not been any studies. So it's not this, we don't use this drug to treat brain AVMs, for example, or prevent them. That's just not what's done right now.